Doc.
Hello, Doc.
Hello, Doc.
Great conversations and education on relevant health issues management. Hello, Doc.
Hello, Doc.
Make a date with our health professionals on the drive with the area gang. Hello, Doc. Hello, Doc.
Hello, Doc.
Good afternoon, Doc.
Good afternoon.
How you doing?
By God's grace, as usual.
We thank God. So we've been looking at pregnancy, contraception and all that. And today I want to look at negative outcomes of pregnancy. Because I think last week we looked at the normal pregnancy and everything that it comes with. So today I want to look at the flip side of the coin, the negative outcomes. So to start the conversation, let's understand what exactly we mean when we talk about the negative outcomes of pregnancy.
Okay, so when we say negative or poor pregnancy outcomes, we mean the adverse events or complications that affect either the mother, the fetus, that's the baby inside the womb, and when the baby is born newly, when the baby comes out. So if there's any issue that maybe once the delivery comes out, the baby is not healthy, the baby is not able to survive, or the mother is not healthy, the mother is not able to withstand the stresses of the normal everyday life, yes, that's the negative outcome.
Okay. And what causes this thing?
Okay, so the commonest cause actually of the negative outcomes is when the pregnancy is unplanned and it's not expected. So usually the mother is not really taking good care of her health and all those things. Poor nutrition is one of the major factors. Other things is the maybe poor health, certain chronic health conditions.
Okay.
And then also lifestyles like drinking alcohol, smoking, using illicit drugs. They are very harmful to both the mother and the baby. And other things like medications that the person might be taking, whether for epilepsy or for hypertension or for a psychiatric condition. Those things can also affect how well the pregnancy would go. So those are some of the commonest causes.
Okay, so you mentioned something about diseases and illnesses. So I want to look at certain underlying medical conditions that can increase the risk of these negative pregnancy outcomes.
So I want to just emphasize that it's not just specifically the disease conditions, but if the disease conditions are not controlled or are not being well managed, that is when they are a threat to the pregnancy. So uncontrolled hypertension, uncontrolled diabetes. If you have sickle cell disease and it's not very stable, you keep having crises and all those things. Also obesity. Now obesity is considered an illness, a physical illness. Yes, so obesity is also a problem. Being underweight is also a problem. And the last one is sexually transmitted diseases.
Okay.
Yeah, so those are mostly the disease conditions we have that affect pregnancy.
In your initial speech, you mentioned about psychiatric medication and all that. Does that also affect or does it have an influence on these negative pregnancy outcomes?
There are some medications that have what we call teratogenic effects. So they affect the development of the embryo. So the embryo will not be able to develop very well, and they will be born with spinal problems and a whole lot of issues. So especially the epilepsy medications, those are generally a problem. And then some of this, not all, but some of the psychiatric medications. And sometimes some antihypertensive medications, especially the lisinopril, ramapril, those kind of pril ending drugs. They are a family of
drugs,
yes, and losartan, and then I think amlodipine, not very safe, but
there are
the commonest one is actually safe.
Okay, but then there are I was just about to ask, there are other safe options, because these are medications that you can't totally get off.
Yes, so the issue is just once you are getting ready to get pregnant, you have to tell your doctor, and then they would switch to a more, should I say,
safer option for you.
Yes.
Okay, that's fine. So we've looked at these whole medical conditions, but let's look at the genetic aspect of this whole conversation. Are there any genetic or chromosomal factors that can also contribute to some of these things?
Okay, so let me talk about genetic conditions. So we have genetic conditions. Sickle cell is a genetic condition. Hemophilia is a genetic condition. And then there's also one genetic condition that tends to make women develop a dilated cardiomyopathy, where once they are pregnant, in the later stages of pregnancy, then the heart gets enlarged and they go into heart failure. So those are a few of the ones that we see quite often.
Okay.
Yes. But when it comes to the fetus, it's a bit multifactorial. Generally, the main chromosomal abnormalities that has to do with at the DNA level, when there's the initial formation of the DNA of the baby and all that.
Yeah.
The commonest one is a Down syndrome. Yes.
Okay.
But the others, most of them are not compatible with life. So most of them end up as miscarriages. And the ones that go to full term, a lot of times the babies don't even live past 1 year of age. And because there's a lot of issues with the babies, like development of different body parts. The heart is not well, the brain is not well formed, a whole lot of issues. Yeah, so those are the things. But when I mentioned the multifactorial, there are some people who have predispositions. So depending on environmental exposures that they may have, so they may be at risk, or they may have the risk factors. So if the mother maybe has poor nutrition, or there's a lot of stress on the mother, or there are exposures to certain toxins and the rest, then they develop those abnormalities at the genetic level.
Okay. So what are some potential complications of each trimester? We have 3 trimesters when it comes to pregnancy, so we want to look at each trimester and then the complications that comes with it.
Okay, so usually the first trimester, that's when we have a lot of the miscarriages. The first trimester is the first 12 weeks. Yes, so a lot of the the miscarriages. One is what I mentioned, the chromosomal abnormalities. There's one we call the blighted ovum. So there's a fertilization that takes place. The gestational sac and the placenta starts forming, but then the embryo itself is not formed, or the embryo disintegrates. So it pretends like a pregnancy, but there's no embryo.
There's no embryo in there.
So then it will go forward, but when they do the scan, then the pregnant woman will realize that the scan will tell you that there's no embryo, but there's a gestational sac. So in that case, we would have to just remove that gestational sac. Then the other one is ectopic pregnancy, which is very common. That's when the fertilization and implantation occurs outside the womb. Yes. So the womb is the only place that can harbor the baby and feed the baby well. If the placenta attaches anywhere else, it will outgrow its space, and then the bed will start bleeding, and then it could lead to death. Yes, so that's it. And we have hyperemesis gravidarum. That's when the pregnant woman vomits too much, and so there's a lot of dehydration and feeling very weak and all that a lot of the times in the first trimester. So the second trimester is from week 13 to week 26. That's when we see the hypertension coming up, the pregnancy-induced hypertension, and that can go forward and lead to preeclampsia. Then preeclampsia leads to eclampsia. Eclampsia is when they have the seizures and all that. So they would have swelling of the feet, or sometimes generalized body swelling, and organ damage in the end if we don't catch it early. Then we have the gestational diabetes. So the person might not have diabetes before pregnancy, but then they'll develop it during the pregnancy. Once they give birth, the diabetes goes away. Yeah.
With the gestational diabetes, does it have an effect on the child?
Yes, it does. So if you don't manage it well, then you would have what we call the big baby syndrome. So the baby is very big, and the the lungs don't develop very well, so they have difficulty with their breathing. Once they are giving birth to.
Okay.
Yeah. Then we have intrauterine growth restriction. So the baby does not grow at the rate that is expected to grow. Yes. So you can start noticing that in the second trimester, and from the scans and all that. So, and that will lead to low birth weights, and low birth weight too has a lot of issues once the baby is born. Then we have preterm labor. It can come in the second or the third trimester as well. So with that one, they might start having contractions and pain as if it's labor pains, but they know it's nowhere near their time to give birth. Yes. So those are the second trimester. And the third trimester, that's from week 27 to week 40. So one thing that usually happens is the preterm premature rupture of membranes, or sometimes it's at term. That's from 38 weeks going. So the baby is ready to come out, but the contractions have not yet started, but the fluid has started leaking out. So this usually happens with people who have what we call cervical insufficiency. It could be because maybe they've had a surgery before and the cervix is not able to keep closed under the weight of the baby, or sometimes it's a multiple gestation, so it's very heavy, twins, so triplets,
presses on the
yes,
cervix.
so it's very heavy on the cervix.
Okay.
Yeah. Then another issue is infections and smoking. Smoking makes the membrane very thin, and so it easily breaks, and then they'll start leaking the fluid
out.
Yeah, and that can cause what we call placental abruption. So that's when the placenta detaches from the womb before delivery is ready. Yes, so the placenta is providing food for the baby, feeding the baby. So once it has detached, that means it no longer has a supply to feed the baby. And if you don't get to it as quickly as possible,
the baby can die.
Yes, okay. Then we have the preterm delivery. So any delivery before 37 weeks is a preterm delivery. And usually they have this respiratory distress syndrome in the babies because before 37 weeks, the lungs are not well matured to be able to survive breathing in the normal air. Yeah. Then stillbirth, we know what stillbirth is. Once you give birth to the baby.
What
and the
exactly causes
dead.
that stillbirth?
A lot of things, a lot of different things. As I mentioned, abruption can cause the stillbirth. Sometimes intrauterine growth restriction. Sometimes we have what we call placental insufficiency. Okay, and that can be caused maybe from infections, or maybe the placenta is not well, should I say, rooted in the uterine wall.
Okay.
Yes. So it might not be able to feed the baby well,
as adequately as it should.
Yes. So the baby, once the baby gets bigger and its requirements are more, the placenta is not able to feed it that way, and then it goes. Yeah.
Interesting. So now that we've looked at all these negative outcomes, finally we want to talk about how we can monitor pregnancy and then minimize the risks as much as possible, so at the end of the day we all get the outcome that we are looking for. Because usually when a woman gets pregnant, the expectation is that after 9 months you give birth to a healthy baby.
Yes.
So now we've seen that sometimes certain things can go wrong, but how are we able to mitigate these risks so it's like to the barest minimum, or if possible it's not there at all?
Yes. So there's a lot you can do. Most you can do is, even before you get pregnant, you get ready. You make sure if you have a sickness, you have it stabilized, your BP is stable, your blood sugars are stable, you are eating healthy diets and all that. Then once you get pregnant, A&C clinic, the antenatal care, or what we call prenatal care clinics at the hospital, they always complain that the midwives are disturbing them.
How early are you supposed to start antenatal?
As early as possible. So from the moment you just find out the pregnancy test is positive, you can go and then you do what they call the booking visit. So the booking visit, they take all your risk factors and everything, do all the lab tests, your kidney function, liver function, sickle cell status, hepatitis
everything.
B. They do all the tests to make sure they know what they are working with, where they are starting from, and then how they can help you. So the earlier you go, the better. It's not that when you go, you are going every week. No.
Because someone told me that antenatal, 5 months, 6 months.
No. You have to go as early as possible, because things can go wrong even in the first trimester. So you have to go as early as possible. Once the booking visits, everything is normal. You probably have maybe 6 weeks before your next visit.
Okay.
But if there are problems and they catch them early enough, then maybe you have more frequent visits so that they can stabilize you, so that the outcome will be as the best.
Okay.
So they would always be doing the checking for all these fetal abnormalities, and once you go, they always check their blood pressures and then their urine to see for signs of either diabetes or signs of preeclampsia. Yeah, and then they also monitor the growth of the baby. So they always do the scans from time to time. They measure the fluid around the baby. Is the fluid enough around the baby? Is the baby growing at the expected rate? And all those things. So it's very important to go for the clinic, and they do a lot of education at the clinics. They even have time for the men. We have pregnancy school. We do pregnancy school for the women and a pregnancy school for the men as well. So the partners will also come and then they educate them on how to do so many different things.
How to support their women during the pregnancy.
It's very interesting. You can come for one of our pregnancy school visits. You would enjoy it.
No, but these days we see a lot of videos on TikTok, social media, where they try to make it as fun as possible. Sometimes we see them dancing, see them jumping about and all that.
So it's a very good initiative, and please, any pregnant women, just come to the hospital, at least get checked up, and we'll see how things go. They do the weight tracking, so they track the weight of the mother, and then they track the weight of the baby
as well.
Yes, so if maybe the mother is losing weight as the pregnancy is going forward, they can track it, and then they'll know how to advise her nutritionally.
Okay.
The fetal monitoring too is also one important thing that the pregnant woman can do, especially later second trimester and in the third trimester. Yes, the scans are important to check for abnormalities, and then the placental function as well. Then they have what we call the kick counts. So you do the fetal kick count, where you measure how much time it takes to feel your body, your baby moving about 10 times. So you count 1 to 10. Usually within 2 hours you should have had your 10 baby kicks, unless the baby is sleeping. So you do it when you feel the baby is active. But if you are doing 24 hours, you're not feeling the baby moving, then you should know that you have to come to the hospital as quickly as possible. Then the lifestyle measures, you have to eat healthy. Exercise. Just because you are pregnant doesn't mean you can't exercise. Don't sit in bed all day. It's not healthy. Yes, you have to move around a bit, and then avoid harmful substances. The last time I mentioned caffeine is not very helpful, so try avoid caffeine as you're avoiding the alcohol, and you're avoiding smoking
as
well.
Usual. Okay. All right. Thank you so much, Doc. As always, I mean, it's very informative talking to you. But I just before we came on, I read that today is World Menstrual Hygiene Day.
Oh, yes.
Our time is up, but I don't know. I just want to say something little in under 30 seconds about menstrual hygiene and all that.
Okay.
Yeah, so for women, of course, obviously.
Yes. So yes, of course, the menstrual hygiene is very important. You should be able to keep yourself clean and all that. I know there are lots of people who do a lot of things. They wash their pads and reuse and all those things. So yes.
Wow.
And those who use tampons, because it's expensive, they will keep it in for more than 24 hours and those things. Those things are all risk factors that can lead to infections. Okay, so try as much as possible to keep the area just clean as possible, and then use the pads as regularly as you can. Yeah.
All right. Thank you so much, Doc, and enjoy the rest of your day.
Thank you.